right, welcome everyone. I'm the chair of the Families and Health Special Interest Group, and we are very excited to offer a webinar today called COVID-19 Pandemic, a multisystemic approach to address family and healthcare provider challenges. And I'd like to take just a minute to introduce our esteemed presenters. Dr. Rowland is a professor of psychiatry at Northwestern University's Feinberg School of Medicine and the co-founder and executive co-director of Chicago Center for Family Health. He's widely recognized for his conceptual model and clinical work with couples and families facing serious health conditions. And his recent book is Helping Couples and Families Navigate Illness and Disability, an Integrated Approach. Dr. Stephanie Trudeau is a postdoctoral research associate with the Thrive Center for Human Development in Pasadena, California, where she currently studies the intersection of spirituality, thriving, and flourishing. She's trained as a medical family therapist and research scientist from the Department of Family Social Science at the University of Minnesota, and her academic expertise utilizes biopsychosocial-spiritual and systemic lens in order to examine illness and recovery across family and social systems. And David Humphreys is a UK-based family psychotherapist working as an independent practitioner in a primary care medical center, seeing people across the lifespan. He is also involved in the development of children and young people's and adult social prescribing services and provides supervision to link workers. He's currently involved in a retrospective evaluation of the service and several other research projects. I'd like to turn it over to the presenters today and thank them for their time.
Hello, everybody. Thank you for your time and for joining us. I am going to kick it off here today for a couple minutes and talk to you guys about the learning objectives, what you're going to hopefully take away from this. What we really want to do is talk to you about how you can use a multisystemic and a family-oriented approach to this ongoing, ever-developing, changing pandemic that we are all thrust upon learning to cope with and within. I'm going to touch on beliefs and how that has come to be sort of a core driver of this pandemic currently. And then at the end, we're going to talk about how the impact of the pandemic does impact our own personal lives and healthcare workers' families. So globally, this has changed a lot since we gave this presentation at the conference just 6-7 weeks ago now. Globally, the daily case count has risen over 22 million. We've had 3 million more deaths. The encouraging number is that we have had 1.2 billion more vaccines since the conference. But as you can see here with this nice little graph here in America, we're not doing so good. We got a pretty high case count. So what does that look like for us nationally? If you look down here on the lower part of the screen, that's where we were during the conference. We have actually started to improve as a country down in the south here after the surge that they had. We've kind of started to come out of that. In my great state of Minnesota, we unfortunately are boasting the highest numbers in the United States and actually 10th in the world right now. So things are kind of a mess. In Minnesota here, and just to quote our own Dr. Michael Osterholm, this is a coronavirus forest fire, just looking for human wood to burn. Globally, we're not all doing very well. And so we were hoping that this presentation would become irrelevant at some point in time. I don't think it is. So I'm going to turn this over to Dr. Rowland, and he's going to start the first part of the presentation.
Okay. It's a pleasure to see all of you. I'm going to talk mostly about the issue of uncertainty, and probably the main point I want to make is that we are not living in a time-limited crisis. This is an ongoing era. And in that sense, the longer this goes on, the more, to me, it becomes analogous to living with a chronic condition as opposed to an acute illness. I think the difference here is, one of the difference is that the illness, so to speak, normally would be in an individual and in a family. And in this case, it's a global illness. And I think that the chronicity and one's reactions to that, even just what's going on now with the Omicron variant, is a very different experience, and it keeps evolving. And as Stephanie said, even since the conference where there was no new variant, one psyche keeps evolving with this. What I'm going to do very briefly is sort of touch on these different levels of uncertainty, which is the larger system, which is more the global level, bring it down to the family system and individual level, and then talk a little bit about ongoing longer term uncertainty. Next slide, please. Next slide. Oh, there we go. Oh, next slide. Ah, there we go. Okay. So if we needed uncertainty navigating, this is sort of the images that we are living in at this time. You cannot see down the road. I mean, I think other than we become more clear that there are going to be more ups and downs in the process. Next slide, please. So the ongoing larger system uncertainty, which again, I think everybody's aware of, is that there's very divergent policies and mandates. We just went to New York to visit our daughter. In New York, you have to present a vaccine card and your proof of identification if you want to go inside. That's not true here in Chicago. What is happening now with borders closing around the Omicron variant is just another expression of all these kinds of uncertainties and multiple approaches. I think the continued waves of new variants and the ongoing unvaccinated population, the figure I heard yesterday was that 6% of the underdeveloped part of the world is vaccinated. That's a horrific number in my view. And then there's questions of the effectiveness of vaccines. Next slide. Dr. Jeremy Green, who's a historian of medicine at Johns Hopkins, said that when the vaccines first came out and we started getting shots in our own arms, so many of us felt physically and emotionally transformed. We had a willful desire to translate that as the pandemic has ended. For me, it was a willful delusion. Next slide, please. So this is from a paper I did a little over a year ago that appeared in September for Family Process, an invited paper. And this was my view of where it was heading. There were recurrent waves, but once we got to vaccines and herd immunity, it was going to peter out. That's wrong. I did not envision where we were, which is, again, we're in a situation of more like a relapsing illness where things come and go. And the experience is very similar in my experience to families that are dealing with chronic illness, and it's particularly a relapsing sort of condition. Next slide. I think we're sort of in like the third recurrence of a relapsing illness. And I think the question is no longer if it's going to occur, it's when will it occur and how significant. And right now we're in the throes of how significant is this variant going to be? We don't know. And for the next couple weeks, we're not going to probably have that kind of information. I've had patients say to me this week, here we go again. And that's accompanied by a greater sense of fear and resignation than I've seen before. More like it's hitting them that it's like people who have a relapsing condition where the second to third round really sinks in that this is going to keep going on. And they're really the despair, and working with despair becomes, I think, much more significant. We'll see more in the weeks ahead, because I think people, as the last note is here, we're flirting with a return of normalcy, and that sort of includes us here for many folks. And that's gotten slammed with, the first sign was borders getting shut down very quickly a few days ago. And that was the sign of like, we're going into another crisis. Next one, please. I think at a broader public health level, the way this is kind of thought about is that this is really an endemic illness like seasonal flu. It's never eradicated. There's going to be new seasonal yearly variants that require new vaccination. And the huge question on that is what will be the new normal? And I can just say personally, it keeps evolving. We're not in a steady state around this. So I think one of the challenges as clinicians is there's no we, they there. We are in a process with the people we see in our practices or in clinics. And one of the things I was saying before we started is that there's a very different level of boundary than I'm accustomed to. I mean, I do family therapy, but people are asked much more directly about how am I doing? How is my personal life? How is my family? And I give answers. It wasn't so common that people would ask those questions regularly. And I'm aware that through the pandemic, this sense of we, particularly generated by this global and continued, so to speak, illness at that level, has generated, for me, even a new normal around my relationships with the people I see. Next slide, please. I think that these are just some of the examples of this uncertainty that our families are living with. When will a spike occur? What is the availability of vaccines? How effective are they? What's the access to those vaccines? The issue of invisible transmission and asymptomatic is, to me, one of the most difficult aspects of this. And the uncertainty if you or family members have gotten COVID-19 or even exposure. The part about the uncertainty around high risk members is families have very diverse risks within their own, within a family. If you live in a household with later life folks, but also kids, the risk is quite different. And yet there's this common risk of, if there's a risk to a child, then that child can bring home the risk and bring it into the family. So there's no separation, as it's a contagious disease, and that's very different than a chronic illness that does not have a contagion as part of it. And also all these effects are with or without illness. In other words, what I just said about living with risk and living with uncertainty, I think is as powerful in many ways, and often more powerful for more people than the actual disease. And the asymptomatic and the invisible transmission, I think, are part of that. Next slide, please. I think the uncertainties that we are sort of in the thick of is this altered sense of time. The sense that as the pandemic persists, days merge into each other as time seems to blur and slow down with no forward momentum. At the beginning of the pandemic, I think there was more of a sense of days blurring. And now it's beginning to feel more like phases of the year, or even people's planning within a longer time frame is blurred, because there's questions of what is okay to do, what can we do, can we start a family? There's a lot of different longer term, as I'll say a little bit more about in a minute, life cycle related questions that this altered sense of time is beginning to impact. And I'm seeing that more rather than the day-to-day or the week-to-week sort of phenomenon. I think the other thing that's becoming very clear is the long-term health and neurocognitive complications of COVID. I'm not going to go into all the aspects of that, but the long haulers, it's both psychological and it's also physical. One of the things that's very, very insidious about COVID is that there are people who are asymptomatic when they get the disease or have very mild symptoms and then develop these long haul symptoms that are out of proportion to the level of disease they had. We're not out of the woods. In other words, when you get a mild version, there are people who wonder, am I going to fall into this category? Am I going to get complications down the road that I'm not aware of now? I think that in the same sense that even if the risks of physical illness, morbidity, and mortality recede, there are these, again, lingering psychological effects, the shock of having lived in or living in prolonged fear of severe illness, isolation, and painful death. I don't think we know yet how that's going to play out over time. So, I mean, the data on that is hard to get a hold of because we're still in the middle of the experience. It's a little bit, though, I find myself, again, drawing much more on the experience of people with chronic illnesses and how there's delayed effects psychologically on the family system, on couples, and on individuals that doesn't necessarily correlate with the level of disease going on. And it's a delayed impact. Often people catch up with their feelings when like a medical crisis is over. And in some senses, I've had that people were beginning to catch up with those feelings, and then you now get hit with another variant, and it sort of distracts you back into that immediate acute phase world. And that's exactly what happens with relapsing illnesses. You can be processing something with a family, and then if there's a relapse, you have to go with there's an immediate crisis again. And I feel like there's a lot of similarities in the experience that I'm seeing more and more as this, because the longer it goes on, the more it resembles to me living with a chronic condition. Next slide, please. Okay, so I mean, Jonathan Moreno, who's a historian of science and medicine at Penn, was very good about that. He said the end of the COVID-19 would be analogous to a cancer that's gone into remission. Still there, but not as deadly. You are never cured. It's always in the background. I mean, I hope that's not true, but I do think when I've worked with people who have had cancer, I've worked with people who had cancer as teenagers, and even when they're 50 years old, one woman put it, if she gets a pain in her little toe, the first thought is I've got a recurrence of cancer. So the experience, the living with the uncertainty never completely goes away. I don't know if there's a version of that with what we're living with, but the endemic part suggests that won't be true, that there will be a part of this that will continue, perhaps not with as much fear, because we don't fear the flu the same way, but I don't see us at that point, and I don't know when we will get to that point at this point. Next slide. These are just some of the relational keys of dealing with the uncertainty. I think acknowledging the uncertainties is important, pacing and avoiding burnout, minimizing relationship imbalances. I think the most important sense there is that there's a we, which when I'm working with people with chronic illness, there's the healthy people, and then there's the people who have the illness. A sense of we, this is a shared challenge, is very important. So particularly in families where somebody has had COVID, I think that's important to keep in mind, just that the person doesn't become identified as that was the person who had COVID or has COVID, but that there's more of a sense of different kinds of, there's caregiving challenges and strain, and then there's physical strains of living with a condition. Sustaining connectedness. One of the things people do more these days is take walks and do some things separate, because there's so much being in on top of each other, so to speak. And also the silver lining would be the increased appreciation for relationships. I think that's been generated. And I think that people are looking at their relationships somewhat differently. When I see the resilience part, that's what I'm seeing, that this whole experience has made people treasure aspects of life in a different way. Next slide, please. Just want to say a few things. It's important. Communication is essential, obviously. The main questions are who will be included or excluded and why, what topics are off limits, such as risk, the life-threatening aspect, or loss. Again, as is true with chronic conditions, there's no evidence kids are heard by age-appropriate communication. And if they ask a question, they deserve an answer. Block communication has all kinds of morbidity associated with it. Next slide, please. I think one of the things here is the periodic or family-oriented discussions, that concept as new information, vaccines, mitigation. I think it's good to sit down as a family. It's important to identify different viewpoints or underlying beliefs, which Stephanie will dive into in a few minutes. Parents can have different ideas about what they should tell their kids, whether their kids should get vaccinated. There's a lot of different levels where you can have conflict or diverse views in the family, legitimate diverse views. I think this is where discussion with PCPs to clarify information, recommendations, hesitancy is key, and utilizing behavioral health to manage conflicting and complex family processes. It's always important to know if there's a complex family to begin with, all of what I've just said is more complex, and they're bringing behavioral health in sooner, I think, is more important. The rest, everybody else can still be subject to these long-term strains, so and can benefit from behavioral health services, maybe in ways that they hadn't thought about before. Next slide. It's my last slide. I think the periodic proactive family discussions is another idea, which is, for instance, if you're planning to start a family, there has to be more planning in relation to the the pandemic than if you were just planning, okay, let's start having a family. Also processing losses. There's a lot of, the longer this goes on, there's, the losses due to COVID, not just the losses through death, but also long-term disability, the long haulers. Other losses that occurred during COVID that hindered grieving and bereavement are very important. I had a case actually it was at the beginning of the pandemic where a man who family I'd known previously, he came to see me after his wife passed away of cancer. We were just beginning to process that. COVID started. He got COVID. He ended up on a ventilator for 13 days. And his odds of dying were about 85%. They had lost a child to cancer. They had a surviving son who had Crohn's disease, lived in another part of the country with 3 kids, was not allowed to visit his father, and the anticipation was he could very well die. He survived, he came out of it, and actually he didn't have long haul symptoms, which just shows you when you're on a ventilator, it doesn't necessarily mean you're gonna have necessarily ongoing issues. But it provided an opportunity for the father and son, number one, to process his experience when the son had to be at a distance while his father very well could have passed away, going into the loss of their mother, and also this kind of altruism of, they were survivors and they wanted to pay it forward in life. So there was a kind of a more ongoing silver lining of what they were going to do. They were processing grief, but they were also thinking, we've got to do something important with our lives together. And that involved commitment to their families, but also more generally. So I think I'll stop at that point, and turn the ball over.
Thanks, John. All right, you guys. Go ahead and utilize the chat box if you feel the need to share what goes on for you. But I'm going to ask you to pay attention to what is going on in your body, your thoughts that are coming up as I go through a few phrases with you. All right. I can trust my body not to get COVID. I'm not going to get the vaccine. It has a microchip in it, or some version of, I don't want the government tracking me. The government is now trying to control my body, not having it. And the pandemic is over. If we're here in Minnesota, you'd almost think it is by the no mask wearing, but I'll try to keep my comments on that to a slight minimum. And my personal favorite is COVID is fake. COVID is fake news. I'm sure many of you have interacted with people that do hold beliefs that are not in accordance with our own. This is something that we have been trained to be able to deal with. The reason I got really interested in this is because for the first time ever, other people's beliefs are actually putting us at harm. Us as providers, us that are seeing patients and families, other people's beliefs are putting other people's family members at harm. And so I really, really love this topic. I'm very passionate about it. And in my opinion, beliefs are one of the core drivers of this pandemic. Throughout COVID-19, and we're seeing it just continue to amp up, there's another pandemic, an infodemic that's going on at the same time. And it is a viral phenomenon. It's misinformation, disinformation, belief in conspiracy theories. And about 20 to 25% is the estimates right now in the US seem to have taken on this anti-science, anti-expert, anti-institutional stance. And one of the things that we're going to be tasked with going forward is how are we going to improve science literacy, and how are we going to meet people where they're at to talk with them about their beliefs. And so that's part of what I'm going to talk about here today. But let's just back it up just a little bit here. What is a belief? And I'm not talking about belief systems or what religion or spirituality that you ascribe to. I'm actually talking about the beliefs that you hold. They're constructed, basically it comes from your history of interactions over time. You develop them in interactions with other people. Beliefs are relational. And how are they sustained? So they start to become intertwined with our self-concept. They end up having cognitions and emotions and actions attached to them. And so if you do struggle to define beliefs, you're not alone. It really depends on what discipline that you're in, or which framework that you come from. But our beliefs essentially are just the lens through which we see our world. And we process the world through our beliefs. So how did people's beliefs come to be the variable that is continuing to predict pandemic outcomes? Do people believe that COVID is real? Do they actually believe that the vaccine is going to protect them? Do they believe in science? Do they believe in their healthcare professionals? Do they have faith in their healthcare professionals? Do they believe in medicine? A lot of where this has come from is people's information ecosystems. And I want you guys to think about that. Like, where are people getting information from? So there is a pervasive spread of misinformation and disinformation on social media. And it is this parallel pandemic, this infodemic. There is a newer account that came out of the kind of Facebook files or the Facebook, the pages, these reports coming out. And Facebook's under a lot of scrutiny right now because at one point they found that they have over 350 million fake accounts. And so a lot of our job, even within our own families, is to help people understand what is real information and what is not real information. What is a viable information source? And what can you actually give merit to when you see something on social media that is continually repeated? And so I'm going to talk about misinformation and disinformation. So misinformation is just the false information that is spread. It is not with intent to be malice. It is just, liking a post without actually reading something, or it might be just retweeting something that you think is viable, is actually a good source. Disinformation, on the other hand, is actually deliberate and misleading. And this is where some of the social media platforms are starting to get attacked because they are putting out true and targeted disinformation campaigns. And so misinformation that is deliberately weaponized becomes disinformation. And so this is really how a lot of this got started, and how some of the anti-science, anti-expert, anti-vaccine campaigns came about. So people's beliefs truly are harming our providers, and misinformation is a public health crisis. So it is our jobs to be able to meet people where they're at, get really, really curious about how they constructed their beliefs and what is sustaining them. Another thing too that we can talk about with families is using a risk tolerance scale. Asking families, how willing are you to get COVID? How willing are you to get it, and how much will it disrupt your life? Starting to ask those questions. If you're really in a practice that is trying to get everybody vaccinated, getting everybody to wear a mask, and then asking them, well, what is the risk tolerance within your family? A husband and wife can have very different risk tolerances. And so if you have the opportunity to have these conversations with your patients over and over again, somebody might finally say, actually, I don't want to get it, but my husband or my partner, anything like that, has a very different risk tolerance than I do. So using some sort of a risk tolerance scale would be something to recommend. And how to talk to patients and families who are vaccine resistant or vaccine hesitant. And unfortunately, that has started to become parallel to the science hesitant, kind of authority hesitant, anybody who may have kind of some good baseline knowledge in this information. There is going to just be a certain number of people that are not going to get vaccinated. Don't use all of your time and energy on those people. There are a certain percentage of people that are reachable and that are movable. That's where you want to start putting your time and energy. Listen to people's concerns. Ask them what they're concerned about the vaccine. What are they concerned about with wearing a mask or social distancing or taking the whole number of precautions that we have now? Just Ask people also, where are they getting their information? What is their information ecosystem? And just be curious. Ask them who their experts are instead of us shoving, Tony Fauci or our experts on them. Ask them where they're getting their information from. And then asking them, can I get you information from somebody that you trust who might also be in our information ecosystem? And then it's also really important for us to tell the truth in a way that people can understand. Right now, it's okay to say, we don't know. We really don't know where this pandemic is going. We don't know how long the vaccines really do work, because now we're seeing, the waning of the efficacy, which is why we're now needing boosters. Continue to be really curious with people. Right now, kind of there's two different camps. There's the people that want to use the tools. They just need instructions and support to do that. Reassure people who got the vaccine that might be saying, I'm not going to get a booster because look, I got it anyway. I had a breakthrough case. We'll continue to reassure them that they did the right thing. They're continue to do the right thing, and empower people. If you're worried about, holidays coming up, for example, I'll use myself as an example. And over Thanksgiving, I set out criteria for my family. I said, there's multiple measures in here that you can choose if you would like to come and join us. And we ended up spending Thanksgiving by ourselves. But I felt empowered to say that because I had enough backing in science to understand what was really going on. And I gave people options. And then the other camp is just those who don't believe, and we have to not give up on them. We really can't give up on them. Maybe they'll use other tools. Maybe if they won't get vaccinated, maybe they'll wear a mask. Maybe they'll think about social distancing. We do have other tools for them to use. Data and shaming doesn't really work with a lot of people. So conversations with families, I hear a lot, just where I'm from here in Minnesota, and then family in North Dakota, people they're not willing to make a small sacrifice. My mentor, Ty Mendenhall, would always say, you don't have one 100-minute conversation. You have 100 one-minute conversations with people, just giving them little bits of information. Even reminding families that this didn't need to happen. If somebody did get sick, just letting them know that there are preventative things out there. We need to start learning how to have respectful disagreements with people. I use this with family members a lot. I just say, I respectfully disagree, but I really wish that you would reconsider. I care about you, and I just wish that you would reconsider. And then for us to have the humility to say, we don't know. I'd already said that before. We don't know a lot right now, and it's okay to say that. So the big takeaway that I want to kind of give to you guys is, for people that aren't willing to do the right things for public health measures and not willing to make the small sacrifices for the better good of the community, instead of looking at them with what's wrong with you, let's ask them what happened to you. Where did people start to get their information from? Did they get hooked on a podcast early on in the pandemic that has absolutely got them down this wormhole now? Where are they getting their information from? And you have to remember, not everybody's experience with medicine is the same. We have to remember that. So what happened to you? What happened to you to mistrust the government? What happened to you to mistrust science? What happened to you to mistrust maybe the experts in your family? Shaming people is not going to change people's behaviors. Be curious, and just be curious and meet them where they are at. And for us as professionals, some of us, we might want to also look at who's in our information ecosystem. Make a list of the people that you trust where you get information from, and then also try to find other people that maybe, the anti-science group can maybe connect with, and try to see where you can bridge that gap. And that is the end of my talk on beliefs. And I'm going to turn it over to David now. Thank you.
Hi guys. Just at the beginning, just to say, if I stop and put the headset on, it's because there might be, the noise level here is okay at the moment, but I'm kind of conscious there are some children in the practice, and sometimes these little guys make noise. So just wanted to flag that to you. At the moment, it's okay. Firstly, let me say thank you for inviting us to kind of present this again. it made me think about the fact that I, of course, as a clinician, I'm in two families. I'm in the families of this place, this PCP setting, this primary care practice, and of course in my own family of origin, my own family, my partner, my children, the rest of it. And it also made me think, as Stephanie was speaking, about how beliefs in those different families are so influential. Interesting enough, in this professional family, there were two, let's just say, quite significant providers who chose not to be vaccinated. And what do you do with that? How does that work when the folk you might expect to really be on it are people who are going, no, I'm not going to do that. And when one of them gets sick, ICU sick, what does this professional family do with that? So it's been really helpful with you guys just kind of asking us to do this again, because for me it's allowed a lot more thinking about this. Next slide, please. Okay, let me talk about what's happened here. A lot of this stuff is going to be very similar to what's happened I'm sure, in the US and Canada. The difference here, Canada's similar, but the difference here, of course, is this is a national health service. So there's a kind of a consistency across most of the healthcare contexts. There's been a shift to electronic and telephone consultations. I'm sure that's true for you guys as well, and that's included behavioral health as well as kind of physicians. Interesting enough, there's a piece of research published here just before the pandemic that said that people really liked telephone consultations, they really liked remote consultations, they found it very positive and very helpful. And yet, when we look at the next slide, when we get to it, we'll see that actually maybe that's not quite the way it's played out. Masked and visored consultations, again, I'm sure that's the case. Face-to-face in exception. I was mentioning just before we started this that in this practice, before I went away on holiday, which was the beginning of last week, I couldn't ever get a room to work in. The room I'm in is too small, so I have to use one of the other consulting rooms. There was no space. I came back Monday, Omnicom, the whole stuff with that. Now there's nobody here. There's one PCP here at the moment, and that's been the case since Monday. So it's a kind of, it takes me into the next one, PCPs and mental health therapists working off-site, team meetings on online platforms. This practice, the access is very, very heavily controlled, and other practices, this practice opened up, and you've got, at the moment, unfettered access. You can just kind of walk in, but I'm aware there are still other practices which are very heavily controlled, and some which will only let you in if you can demonstrate you've been vaccinated, and some are actually asking for negative lateral flow tests. At the beginning of the pandemic, with this, again, I'm sure there was the same thing in the US. Practices were classified on the basis of red, orange, and green. And that was about, I think, trying to enable all of us to work out quite where the risks sat. Next slide, please. This slide, as you can see, is the way that GP or PCP appointments have changed. There is, pre-lockdown 2019, 25 million face-to-face consultations. It's bumping along at about 14 million, and that was in July 21. I think it probably may have gone up slightly in the face of a lot of criticism. In the press, a kind of implication that somehow PCPs were avoiding moving to face-to-face. But I would imagine if we look to the most recent data, and I'm not sure whether it's available yet, it may show another drop back in face-to-face meetings. Next slide, please. Okay, this is really, again, is stuff which I think is mirrored in the US. There's a lot of research here concerning the traumatizing impact of uncertainty on healthcare professionals caring through the pandemic, particularly those working in COVID wards, particularly those working in ICU type settings or working in hospitals and other residential care contexts. And there have been a number of responses to that, some informal, and I belong to an organisation which had responded to the need to provide kind of support for HCPs in that, traumatized HCPs. What is emerging now here is a lot more willingness to talk about the traumatic impact and the way that that is affecting the availability of the workforce, because there are now here in the UK there are workforce issues in terms of the number of people who are just available. Not they're employed, but they're not actually available because they're not at work. But there isn't so much. There's not so much research on the impact of uncertainty on primary care. However, studies suggest a significant measurable increase in depression and anxiety in healthcare professionals' families. And this, not surprisingly, seems to be related to concern for their loved ones during the pandemic, and the things we've already mentioned. John's talked about risk. I think uncertainty has been mentioned. All of those things. Next slide, please. One paper which was published last year, which is quite interesting, which is very much about healthcare professionals' families. In fact, it's practically the only paper I could find at that point, and I'm not sure there's anything else currently available. Seemed to identify in the sample size was about 150 across actually 3 countries: Germany, Nigeria and the UK. It suggests there was a kind of increased uncertainty about their loved one's safety and risk of death, loneliness generated from HCPs working long shifts. Here in the UK, the HCP's shifts were moved to 12-hour shifts. Everybody working in those kinds of contexts worked 12-hour shifts. And what accompanied that was a need to isolate away from home in hotels, which were obviously, used for that particular purpose. There was also, again, not surprisingly, the way that the reports in the press, in various media about HCPs getting sick, HCPs dying, I think again raised this issue of not unsurprisingly panic. And the worries about the transmission of infection by that HCP unwittingly, because we've talked about already the asymptomatic nature of it, and in turn HCP's anxiety that they may infect their family members. Next slide, please. This slide really is to me is a really, really important slide. I have to start by saying that I'm conscious that BAME as a terminology is for many people, or for some people, contested. It's currently the standard terminology that is used here in the UK. It is not necessarily one I would reach for, but because it occurs in much of the literature, I think it's quite it's important to acknowledge that. From fairly early on, the press were reporting that the impact on Black and Asian minority ethnic, to use the terminology, groups seemed to be disproportionate. A lot of it was anecdotal stuff, but what I've actually presented here is a number of sources which have given some substance to that. The first one, which is from a report on the disparities in the risk of outcomes of COVID-19, very clearly identified there were a much higher number of BAME staff among those who had died. The other paper, which talks about deaths in healthcare workers due to COVID-19, clearly identifies that ethnicity was a significant factor, and that was here we're talking about a threefold increase, more than the portion in the NHS workforce. Again, anecdotally, but also there is some evidence that BAME healthcare professionals were more often to be in the front line, partly because of their proportion in the NHS as an employer, but also I think there are questions about why that is, which haven't been answered. Next slide, please. Again, this is some more information. To me, this is a kind of crucial issue that have to be considered. The first one talks about, Black, Asian and minority ethnic doctors felt pressured to work in settings with inadequate PPE. The issue of PPE was a major one in the UK in the first lockdown and well into the kind of period after that, and still has not gone away. There is the guy, the Muslim anaesthetist, talking about him being forced to shave his beard because of the unavailability of sorts of masks. Likewise, in the College of Nursing report, 70% of respondents then felt pressured to care for a patient without adequate protection, as outlined in the current PPE guidance. Almost double the 45% of white respondents who had felt this pressure. This stuff is, this particular report, it came out very opportunely towards the end, well, not in midst of the first lockdown, and is basically a review carried out by Doreen Lawrence, whose son was killed as a part of a racist attack some 10 years previously by 4 young white men who were never brought to justice. Next slide, please. Example of the pandemic's impact. There is currently no published research in the UK, and I'm talking there about the families, the impact on families. There are other ideas which I've heard mentioned when I talk with colleagues. The idea that somehow if I'm a healthcare professional, a Black and Asian minority ethnic healthcare profession, there's less protection, more risk of death. I had a colleague, HCB, a nurse, ICU nurse, who basically was in a hotel, went home to see his family and looked through the window, but of course they didn't know he was there and he didn't want to let on, and actually all he said is it made it worse, it wouldn't make it any easier. Another narrative, an emerging narrative, is going from being in a family proud of being clapped to PCPs being castigated for not enough face-to-face appointments. I mean, I think that's just shameful, but there you go. Another colleague, being in the family of a PCP makes me depressed and anxious, and that's been reflected nationally with the increased departure from primary care of PCPs. Next slide, please. If there's a next slide, is there a next slide? It's the references. Okay, yeah, that's the references. I think I've got all that to say. I'm quite happy to answer any questions that people may have about that, but hey, that's me done.
All right, we'll open the floor for any questions that people have. I'm going to zoom through the chat here since I did not have an opportunity to look at that. questions? No comments?
I'll jump in with a question. This is actually, I think I had this on my mind when you gave the presentation in CFHA too. I don't know if you have any idea about this, but there's also the piece around discrepancy when people in a family context relationally think that they are on the same page, but actually in terms of behavior are not, but don't necessarily have insight around that. And I find that in some ways more challenging because they don't necessarily have awareness of where the
It looks like Jessica Goodman is talking, but you're muted, Jessica. I don't know if you know that.
Oh, yeah, I'm
Can you
actually
hear me?
not muted. Can you hear me?
I can hear her.
Yeah.
Oh, okay. Did you hear me before?
Mm-hmm.
Oh, okay. Then I'm just gonna stop talking.
I guess my question, Jessica, is in those situations, have families intentionally sat down and talked about either their beliefs or what guides them in before they get to the discrepant behaviors? Because again, this is no different than my work over the years with chronic illnesses. It's amazing what families haven't talked about. So I mean, you assume people read papers and whatever, but they have not actually had a conversation with each other with enough granularity to get to what we're talking about. It's one thing to say, in general, I agree with you, I should wear a mask, but then if I go out and in 40% of the situations I don't wear one, I'm only partially buying, into the, so I think there's conversations in the family, and then if there's discrepant beliefs and that can't be resolved at that level, has there been also a consultation or some kind of conversation with a healthcare provider who's trusted enough that could help when there's differing beliefs?
Yeah, that's really helpful. Really going back to like, well, we might all consume the same information and say we agree, but what does that really mean? And what does that really look like for each of us?
Mm-hmm.
And then do we need to bring in somebody else to bridge the gap, or can we talk through this ourselves and come to some kind of shared understanding of whatever we thought was our core value? Thank you.
I appreciated the just appreciated the presentation on multiple levels on, like, I think probably everyone has examined this from a kind of an existential or spiritual point of view, maybe not everyone, but and so your perspective on the we and they conversation was really helpful. And I've heard people talk about it, but not put so succinctly. And then the chronic or the chronicity of it all. And I have been feeling like, as a parent of a 17-year-old and a 12-year-old, thinking about the chronicity of some other things that were not yelling as loudly as this has yelled. And this has called attention to those things. And so, I don't know, I guess I'm still in the process of solidifying the meaning I've made around all of this, both personally and from a professional point of view. And then also thinking about the conversation, I think it was Stephanie's portion of how to talk to someone, and my husband and I have talked. We're pretty much on the same page, but with folks friends of ours who've chosen not to, and we've even lost a friend who was our age from it, who was not vaccinated, and just still kind of like, it's just fascinating to me to see how entrenched, I mean, it couldn't get any closer almost. And how do you have that conversation? But I appreciated Stephanie saying, that shaming, and we would never do that or come at it from that perspective, but that never works, because we just continue to talk to each other about, if it ever comes up, how do we do it in a way that's helpful, or might, or even what category do they fall in? Or are they in the category that they're never going to change that thought, or I don't know. So lots of different elements, and appreciated the presentation very much.
Mm-hmm.
I'll chime in as well. This was excellent. Thank you to all the presenters for your work and your thoughtfulness for this presentation. I was not able to attend during the CFHA conference, so I'm so glad I was able to attend today. And I think too, John, just in regards to your section, it was really powerful having you apply your, chronic illness model to COVID, and just thinking about it more broadly in regards to engaging in conversations with patients. And then Stephanie, I really liked how you highlighted Ty's point of it's not a 100-minute conversation, it's 101-minute conversations. And I think that that is just really important when working with patients, and really even just, communicating with other members of, family and friends, just keeping that at the forefront and knowing that change takes time. And it's those small moments of curiosity, and wanting to understand their understanding and their framework. So just professionally and personally, this is very powerful. So thank you all.
One of the things I've noticed is, some families live with a chronically ill member or kids who've had a chronic illness. There's more wisdom. I mean, there's transferable knowledge. And again, this is a difference in the sense everybody's at risk, but I have several people in my practice who have HIV, and in some senses, they've had a lot of experience at dealing with an infectious condition in their interpersonal, in their relationships. So I think one of the things I've always thought about is, like, if somebody develops a chronic illness, have they had experiences before they can draw on to apply? And I think it's worth remembering here that people may have transferable knowledge and, have had conversations about difficult things before, or brought kids into conversations they normally wouldn't have had if there wasn't a significant illness. So.
Absolutely.
Yeah, and the link that I just put in the chat, so the risk tolerance scale that I got was actually from preemie association. So when I've talked to other families who have had preemies, when they talk about the lockdown, they're like, yeah, we did that for a year. We already knew how to do that. So there are families, and John, that's a great point, that already have transferable skills.
Well, I guess for me, what is interesting is coming out when I was thinking about Jessica's kind of comment, was the whole place of development of beliefs, the way the beliefs evolve in relation to things like the duration, in this case, of the pandemic. I was traveling back from France on Sunday with my son, who is 27, and he's, he wears a mask, he gets a vaccination, and he was going to Switzerland for Christmas. We're traveling back, and he gets this message that Switzerland is shut down. And this guy, my son, he's raging. He's kind of like, well, I live my life. Look, I've done all the stuff. I've had my jabs, I wear my masks, I do all of this kind of stuff. And here I am, I can't go to Switzerland for Christmas, which kind of sounds pathetic at one level, but he then kind of says, well, look, I'm a young guy, I want to live my life. What am I supposed to do? Put my life on hold, and blah, 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 blah. And it seems to me there's a whole developmental context to this, isn't it? It's not simply about who believes and who doesn't believe. It's where those beliefs sit in relation to where you are in your life aspirations, and in terms of how you think about those.
I was thinking that, transitions, again, with chronic illness, when a kid is approaching a transition like a senior in high school, it's always valuable to ask, how is the condition itself affect your thinking about your future? In some cases, it's more obvious, but in some cases, it's not so obvious. And I think it's worth including, I guess I'm coming to the point where I'm including that as people are approaching different transitions, as does the pandemic, does living with the uncertainty affecting how you think about whatever it is in the next phase of your life. So I find myself doing that more than I would have, certainly even a year ago. It just seems like it's because it's going to persist, that it's really important that we ask those questions, or at least provide the question so that family members can think about it.
Well, this is a great place to wrap up. Thank you, David, John, and Stephanie, for your wonderful presentation. And thank you all for joining us today and engaging with this material. I hope you all have a good end of the year and a happy new year as well.
Thank you.
Thank you,
Thank you.
everybody.
Thank you. Thank you.
Bye.
Bye-bye.